satisfied you. So do not oppress the orphan, nor repulse the beggar, and proclaim the blessings of your Lord. Sadaqallahu alazim.
Thank you, Mahmood. It is now my great pleasure to invite Dr. Muslima Ijaz to deliver the welcome address. Dr. Muslima Ijaz is a medical doctor and public health researcher at AKU. She holds a master's and a PhD in epidemiology from Karolinska Institute, Sweden, and completed her postdoctoral training as an NIH Fogarty Fellow at the University of Alabama at Birmingham. Her work spans HIV research across multiple countries, blending clinical, epidemiological, and community-based approaches to address public health challenges. Please join me in welcoming Dr. Muslima Ijaz.
Bismillah ar-Rahman ar-Rahim and Assalamu alaikum. Very good afternoon, everyone. I'm deeply grateful for the presence of our distinguished guests, the Dean, Aga Khan Medical University, Professor Karim Namji, Project Director, EPI, Dr. Raj Kumar, respected government officials, technical partners, civil society leaders, NGOs, educators, members of the media, members of the community, and our valued health professionals, faculty, and frontline workers. It is my immense pleasure and honor to welcome you all to this important seminar on HPV vaccination awareness. Your time and commitment reflect a shared vision to safeguard the health and the futures of our adolescent girls in Pakistan. This is not only a matter of public health, it is a matter of justice, equity, and dignity of our future generations. We stand today at the threshold of a historic opportunity. Sindh is the first province in Pakistan to initiate the HPV vaccine rollout, a bold and commendable step by Ministry of Health and EPI. The HPV vaccine is not just the health intervention, it is a gift of protection. Science is offering us the chance to prevent cervical cancer before it begins. Globally, cervical cancer claims over 300,000 women's lives each year, with the greatest toll in low and middle income countries. In Pakistan, it remains the leading cancers in women, often diagnosed far too late. But today, we are not here to speak only of disease. We are here to speak hope. We are here to speak prevention, and we are here to speak collective responsibility. The vaccine works best for girls between 9 and 14 years, so our strategies must be inclusive, reaching those in schools, those out of schools, and those living in the marginalized and hard-to-reach communities. We must also address barriers shaped by the gender norms, the social structures, and the religious concerns. Investing in adolescent health is not optional. It is a national responsibility. Healthy girls grows into empowered women, and empowered women strengthen families, communities, and nations. Special recognition must go to our nurses, lady health workers, and EPI vaccinators. You are not only delivering vaccines, you are building trust, breaking myths, and bridging science with society. You often work in challenging environments, navigating cultural sensitivities with empathy and respect. This is not just the health delivery. This is social transformation work. We know that biomedical facts alone do not guarantee acceptance. In our context, decisions about girls' health are often mediated through fathers, elders, and community leaders. And this is why engaging religious scholars, teachers, and local influencers is not an add-on. It is essential. And here we are reminded of the words of our beloved Prophet Muhammad sallallahu alaihi wasallam. Allah has not sent down a disease except that He has also sent down its cure. This is a profound encouragement that prevention and treatment are part of our responsibility as a community. The seminar brings these perspectives together so that our rollout is not only medically sound, but also socially accepted and owned by the community we serve. Let us ensure that no girl in Pakistan is denied the protection that science, faith, and society can offer her. Let this not just be a public health milestone, but a moral triumph. May Allah subhanahu wa ta'ala bless our efforts with acceptance and lasting impact. Ameen. Thank you.
Thank you, Dr. Muslima, especially for setting the importance of the work that we're doing here. Next, we have the opening remarks from the Distinguished Chair of Pediatrics and Child Health, Dr. Fyezah Jehan. Dr. Fyezah Jehan is a professor and a pediatric infectious disease specialist at the Aga Khan University. She is also an infectious disease epidemiologist and a researcher in maternal, newborn, and child health. Her work in population-based epidemiology studies, clinical trials, and translational research has led to significant advancements in understanding and addressing preventable causes of maternal and newborn mortality. From studying the burden and determinants of HPV carriage in marginalized communities to leading Pakistan's participation as principal investigator in the GLOBE-HPV project, she has advanced national and global understanding of HPV epidemiology. Her research has directly addressed policy and practice, especially related to childhood immunization and management of infectious diseases such as neonatal sepsis and pneumonia in low and middle-income countries. Through her leadership, she has built multidisciplinary teams and robust platforms, including for systems biology and bioinformatics. She was an initial member of the HPV vaccine introduction in the Sindh Advisory Group. Dr. Jehan is a member of the Strategic and Technical Advisory Group of Experts for Maternal, Newborn, and Child Health and Nutrition. She has over 150 publications and in highly cited journals and serves on the editorial board of several journals such as the ADC and PLOS GPH. She is part of the International Health Partnership Advisory Council at JHU and a board faculty member in the Medical Research Council. But most importantly, she is a mentor and an inspiration to many budding pediatricians, researchers, and tomorrow's change makers, including myself. Please welcome Dr. Fyezah Jehan.
Thank you, Jhpiego, for that very generous introduction. A very warm welcome to all of you. And I will quickly begin with my talk because we are running a little late in time, but we'll try to catch up as we progress. So, to the people in the audience, if I were to ask you how many women actually die from cervical cancer in Pakistan every year, is it more than 300? Is it more than 3,000? Or is it more than 300,000? How many people think that it's more than 300? 300? 3,000? 300,000? So the burden is substantial. And the answer is actually 3,000 women every single year. Now, if I told you that there's one vaccine, a single dose of which can prevent all of this mortality, who here will refuse to take that vaccine or refuse it to give their girls? Anyone? It's a given. And that is why we are all here to talk about this simple, very, very scientifically proven, cost-effective intervention and how we can make sure that it reaches to all the Pakistani girls who need it. So HPV, or commonly, it's called the human papillomavirus, is actually a very, very common virus. And most people, including you and me, will be infected by it at some point. But for many, the infection actually goes away on its own. In a certain population and, with certain high-risk types, especially the types which we will be discussing more today, HPV 16 and 18, can cause cervical cancer. And the problem is that once this infection takes hold in the body, it results in a chronic infection. And then by the time the symptoms of cervical cancer manifest, it is already and often too late. As has often been the case in Sindh, for most immunizations, the province has led the introduction of new vaccines. So Sindh has actually is debuting the province-wide HPV rollout, in the country, and this is planned in the coming month. Therefore, in our seminar, what we have done is we have brought together the leaders from the education, health, health delivery partners, from the government, community and faith-based sectors, all the people who have been part of this collective effort to share and discuss the strategy that will be adopted. Our goal today is to allow academia, media, and the public to align behind the single higher purpose of making this HPV vaccine intervention rollout a complete and resounding success. We will also share the research conducted at the Aga Khan University that has been funded by the Gates Foundation and the International Vaccine Institute, and how that data strengthens and informs a lot of things which are already part of the strategy. As with any vaccine rollout, this is a collective effort, and it starts with leadership that sees a picture that is bigger than themselves, and a picture that is not only related to health, but all the necessary sectors that connect with health, such as education, policy, and others. And this is a good segue because at Aga Khan University, we're fortunate to also have great leadership. And it is my pleasure to invite our Dean of the Medical College, Dr. Dean Damji. Today is Dean Damji's second day on the job. So what I'm going to do now is I will call back our MC, who will formally introduce him to the podium. Thank you, guys, and have a good seminar.
Thank you, Dr. Fyezah. Next, we have, as mentioned by Dr. Fyezah, the privilege of hearing from the Dean of the Medical College, Dr. Karim Damji. Dr. Karim Damji is the newly appointed Dean of the Medical College. He was the inaugural Lela Endowed Chair of the Department of Ophthalmology and Visual Sciences at AQ and has been part of the AQ family for nearly 3 decades, serving in Pakistan, East Africa, and Afghanistan. Dr. Damji trained in Canada and the United States, completing medical school and a research fellowship in ocular pathology at the University of British Columbia, residency at University of Ottawa, and fellowships in ophthalmic genetics and glaucoma at Duke University, along with an executive MBA from Queen's University. He previously served as residency program director at both the University of Ottawa and the University of Alberta, and as chair of the Department of Ophthalmology at Alberta. With over 180 peer-reviewed publications, leadership roles, and editorial contributions, Dr. Damji has been honored with numerous awards for excellence in teaching, research, humanism, and global health, including the University of British Columbia Alumni Global Citizenship Award. Please join me in welcoming Dr. Damji.
Thank you so much, Javeri, and Bismillahir Rahmanir Rahim. Assalamu alaikum and good afternoon. It's a real privilege for me to be here, and I can't think of a better event than this to be able to attend and to really welcome all of you. So it's my honor to welcome our distinguished representatives from the Ministry of Health, Government of Pakistan, and some people, of course, will still be arriving, the World Health Organization, EPI Pakistan, Jhpiego, UNICEF, NITAG, IVI. I think I have to get used to these acronyms, as well as colleagues from civil society and our esteemed AKU faculty, students, and trainees. So, when we think about the role that AKU plays as a powerful civil society organization, it is really important that we think about how we can advance knowledge, but then also use our social conscience, which is, of course, what Aga Khan Development Network is all about, to act. And in this case, of course, it's a very powerful action that will, inshallah, will unfold with prevention. I think from what I understand, many years coming. And I'm so pleased that this time has arrived, which is an important milestone for public health in Pakistan, and that the vaccine rollout is now scheduled. So our Department of Pediatrics and Child Health, I'd like to commend Dr. Fyezah and all of the team members involved, has been deeply committed to advancing research in the area of vaccines. And just to give you an idea, Data has been generated either before or during vaccine rollout, post-vaccine assessments, etc., for typhoid, rotavirus, pneumococcus, Hib, IPV, and I'm sure I'm missing a few more acronyms and vaccines. But look, it's phenomenal work. So I just want to compliment all of you. Too many names, unfortunately, to call out for the great work that's being done. And in this case, it's the first prevalence and incidence study on HPV infection and associated risk factors in girls and women from both urban and rural Pakistan, and of course, supported by the Gates Foundation. So we're very grateful for that support. So today, I think the findings will be shared. There'll be an opportunity for dialogue and alignment of stakeholders, and then crucial information that will support the government's efforts. And again, here, AKU, in partnership with other civil society organizations, but also with government. So it's a good example of a public civil society, and additional stakeholder partnership to ensure a successful rollout, inshallah. So it makes me very proud to see this unfolding and to see the good work that all of you are doing. I think holding this dialogue is crucial to share scientific evidence, but also to address the concerns that were raised earlier, and to make sure there's an environment of trust and that all partners are aligned. So I just want to take this opportunity on my second day to wish you all the very best in the dialogue and inshallah in the implementation. And I look forward to seeing the results in the future and the impact on our population and healthy girls and women, inshallah. Thank you so much.
Thank you, Dr. Damji. With the stage set, we will now move into the core of our seminar, the plenary talks. Our speakers will share global evidence, discuss prevention strategies, and shed light on challenges and opportunities for an effective vaccine rollout. Our first session focuses on the current landscape of HPV, and our very first speaker is Dr. Fyezah Jehan, who will provide a detailed overview of the HPV burden in Pakistan. Dr. Fyezah, the floor is yours.
I have a presentation. Thank you. All right. So as we mentioned earlier, that we have a very high mortality where women die from cancer, and this is entirely preventable. So the HPV vaccine, which we are mostly discussing today, is what will stop most of these deaths. And that's why we are here to talk about the findings from the GLOBE-HPV study. GLOBE stands for Global Epidemiology of HPV. And we are going to talk about the results from Pakistan. I'll walk you through what HPV is, how big the problem here is in Pakistan, what we have learned from the GLOBE study, and what needs to happen if we want the vaccine to reach to girls before they actually get infected and sick. HPV, as I previously mentioned, is a common virus, and it's a part of the papillomavirus, and it is a non-enveloped DNA virus. It is sexually transmitted, and as per WHO, we have 291 million women globally who have been infected with the virus. The average prevalence in anybody, in healthy women is 10%. And the rates of infection depend on many different factors, such as the age, gender, sexual behavior, and geography. The human papillomavirus comes in many different types. There are almost more than 200 types which are known to us. And these are mostly classified for risk purposes into what we call as the the low-risk types, and the high-risk types. So the infections in the low risk are mostly asymptomatic and self-resolving. And the high-risk types, which are HPV 16 and 18, the virus strains that are of a special interest, are part of the other 14 high-risk type HPVs that are responsible for 70 to 80% of all cervical cancer. So as I mentioned, the HPV virus results in many different disorders, specifically in cervical cancer, where the HPV virus contributes to 91% of the cause of all cervical cancers. In terms of the global burden, over 600,000 women are diagnosed annually, and this is a huge burden. Most of these deaths and among these women, about 340,000 die annually, and most of these deaths actually happen, as you can see, in countries like ours. So Pakistan is here, and Pakistan has, a very high burden of deaths related to cervical cancer. So coming to Pakistan, here, you have about 73 or 74 million women who remain at risk of cervical cancer. Every year, we have about 5,000 cases, 3,000 deaths, and almost 9 out of the 10 cases actually are caused by just the two very common types, which are HPV 16 and 18. Emphasizing again that these deaths are entirely preventable, but only if we act early. As you can see here, that the age standardized cervical cancer incidence rate is 6.1 per 100,000 women in Pakistan, and this is way above the cutoff of 4 or fewer cases of cervical cancer that is recommended by WHO for the countries. So Pakistan has a long way to go, and just for reinforcement, treatment and prevention of cervical cancer is part of the Sustainable Development Goal 3, which is very critical for overall health and well-being. Now, some say that there are gaps, there are others who don't. In 2020, the WHO adopted a global strategy for elimination of cervical cancer. And what it recommends is that 90% of all girls between 9 to 14 years of age should receive the vaccine by 2030. However, despite all of this impetus, the global uptake of HPV vaccine among girls remains low at less than 15%, about 13%, and this is mostly because there has been a delay in rollout of the vaccine in the countries. So for Pakistan, it has always been the question that there is limited data. So while we have data on cervical cancer and cervical deaths from hospitals, the data on the prevalence and incidence of HPV infection, which could potentially inform the immediate vaccine response and the effect of the immunization, is actually still limited. And this was one of the goals to generate this kind of data in the GLOBE-HPV study. Also important to emphasize that Pakistan does not currently have any screening or formal treatment programs in place for cervical cancer, and these treatments actually only are accessible to a very small segment of the population, mostly in tertiary care centers. So the GLOBE study in Pakistan is part of one of 8 sites, 3 in South Asia and 5 in Sub-Saharan Africa. The overall objectives of the GLOBE study were to test at a single time point the proportion of girls and women between 9 to 50 years who have HPV 16 or 18 infection, and also look at their risk factors. The other objective was to describe the knowledge, attitudes, and beliefs regarding the vaccination and cervical cancer screening treatment, to characterize the perceptions of gender norms and stigma, and to estimate the incidence of HPV 16 or 18 infection among married women. So while the first three objectives are cross-sectional, the incidence study, where we are regularly following these women, that the results of those are still in process. So the aim of this study is to see what proportion of girls and women have persistent infection and what is the rate of acquisition of new infections. So this table is again showing you, the different study types that we have. The cross-sectional studies have been completed. So cross-sectional study 1 is conducted in the peri-urban urban communities of District Korangi and Malir, with a sample size of 2,000 and the target age is 9 to 50 years. And here the sample type that has been used is a validated tool where we are doing urine for HPV detection. Also in this study, in a subsample, we have also done self-collected vaginal swabs, where we have been able to show that there is near 100% concordance between urine detection of HPV as well as the self-collected vaginal swab. The second study is conducted in two tehsils, Juhi and Dadu of Sindh. These are primarily rural, and again with the same sample size and type of population and the collection methodology. We also did the female sex workers, which were enrolled with Bridge Consultant Foundation. So did a cross-sectional survey of prevalence there. Here the population was FSWs who are less than 30 years of age. And here the methodology used was self-collected vaginal swabs. And then I mentioned the peri-urban urban longitudinal study, which is currently ongoing, and this study will complete sometime in December next year. This is where the peri-urban sites are. So this is Ibrahim Hedri, Ali Akbar Shah, Ready Goat and Bhes Colony, and some of the surrounding areas. And we used population-based sampling over there as well as here, which is our rural site. So jumping quickly to the findings, the important thing to see is, so the table above is for urban and the table below is for rural. So the really good news here is that in both the urban, in the group 9 to 14 years of age, and in the rural, in the group 9 to 14 years of age, the prevalence of HPV is 0. And there we did not detect any 16-18 infection there. And this is really the age before exposure. And this is also the window for when we will be giving the girls their vaccines. But when we look at older women, we start to see not just 16 and 18 types, but we also start seeing all the other types. And some of them are high risk, which really tells us that there's ongoing transmission of the virus in the community. Now remember that these are healthy women who are living at home, and this has mostly been done through a home-based survey. So with this ongoing HPV transmission, it really emphasizes how important this preventive effort of vaccination is, and I think it also makes, because we have all these women who will not receive the vaccine, right? These older women who will not receive the vaccine. So I'm talking about the women in the dark blue bar, which are 31 to 50 years of age. So you see that, we not only do we need the vaccine, but we also need organized cervical cancer screening to detect the early cancer and to provide treatment before it's too late. In the urban areas, what we have seen is that women who are residing in more wealthier homes have a reduced risk of infection. And the terminology is adjusted odds ratio, but basically it means that these women have a 90% less likely risk compared to the poor women. So it is the poor and vulnerable women who are more at risk of the infection. Now, there may be many reasons for that, but what we do see is that the risk jumps twofold, and even, it becomes almost twofold when there are other sexual type risks present. And here we are talking about partners or husband-wife situation where we see that the risk increases if the woman has had more than 2 lifetime partners, or her husband has had other partners. In the rural areas, in the rural areas, what we saw that while the risk or the odds was increasing, as the age of the girl increased, but the wives of the husbands who spent up to half a month away from home, they also have a threefold increased risk of HPV infection. We also saw that 95% of the women who we surveyed had never even heard of the HPV vaccine. And I know that there's a lot of news in the media about the lack of awareness. But the important part that we saw was that there is a huge trust in vaccination. People here, so almost 90, while 95% had not heard of the vaccine and the overall knowledge was really low, less than 1%, we do see that a very high trust when the government recommends the vaccine. So almost 90% said they will take the vaccine if the government recommends it. More than 90% said they will take it on the doctor's advice. And more than 90% said that they will take it if there is religious support for the vaccine. So this really means that the people trust government recommendations and their doctor's advice. We also saw that over 3/4, about 76 to 81%, said they want cervical cancer or HPV screening. And between 79% and 80% said that they would take the vaccine or have their daughters vaccinated. So overall, good news for the program. The barriers that were identified were mostly access issues. Access issues in terms of availability of the vaccine as well as the ability to take the vaccine. There were a few who said that they will get objections from their husband or other family members. There were minor concerns about painful vaccination and side effects, and these are generally seen in other, vaccine attitude surveys. 90% had absolutely no concerns related to the vaccination. There were a small number who feared the result, and there were some who were worried about embarrassment in taking the vaccine because there is a general conception that the vaccine is not needed, right? Cost was a very important concern, but since the vaccine will be introduced through the program, this will also be managed. We also found something really interesting and important. So, in terms of the acceptability, the reluctance was more in mothers of the girls rather than the girls themselves. So, about 10% said mothers said they will not want to vaccinate their daughters, like I mentioned previously, and 5% of the girls themselves said that they will not want the vaccine. So, this reluctance was more likely if they were residing in the urban area and in particularly the Bengali and the Urdu speaking communities as compared to the others. The vaccine intentions of the mother did not get affected by the girl's knowledge about cervical cancer and HPV. In fact, mothers who exhibited a greater knowledge of cervical cancer showed a more risk of not wanting to not wanting to vaccinate their daughters compared to those who had never heard of it. So this really shows that the strongest drivers of acceptance are when the mother understands both the benefits and the safety of the vaccine, and when they do not have any general concerns related to other childhood vaccines. And this tells us that our messaging has to target parents, especially moms, and the focus is not just on awareness, because clearly awareness is not working here. It is trust. and reassurance and addressing the concerns as they happen head on. And I'm sure that there's a lot of memory in the program from, the typhoid rollout in a similar type of population where it was given through the school program. So I'm sure that there's going to be a lot of anticipation of all of this, and we will be able to manage it better. So we also looked at some of the determinants of, both the infection as well as the uptake of immunization. So we looked at what of female empowerment in the urban side, and what we saw here is that using different questions to assess empowerment, 1/3 of the women almost had the main role in decision making regarding use of their own income. So this just shows the financial autonomy of these women that we had tested and we had interviewed. On the rural side, we asked the same questions, and here we see that the proportion of women who could be main decision makers was overall lower, you know, especially in the age that where they can be decision makers. So it was quite low, as you can see. However, in the youngest age group, these women were reporting a main role, in a rather bigger role of making decisions about their own use of income and health compared to the urban women or urban girls. We also looked at the prevalence of HPV in female sex workers, and this is, very gratifying work that we did with the Bridge Foundation. And thank you to Dr. Sharaf, who's also here in the audience. So in collaboration with BCF, we mapped we used the mapping that BCF has done in the Karachi Koti Khanas and the other topologies, and identified 250 female sexual workers and screened them for HPV infection and also interviewed them. So in this population, we saw alarmingly high rates of prevalence. So overall prevalence of any HPV type was up to 60%, and it was 20% for the 16 and 18 types. And yeah. So the So the conclusion here was that the overall HPV prevalence, like I mentioned, is high. 72%, 72% of women had multiple types of infections. And the most prevalent high-risk types were not HPV 16 and 18, but they were HPV 5, HPV 42, and HPV 16. The prevalence of HPV 18 was slightly low. Only 5% of the participants had any knowledge of cervical cancer. No one was aware of the vaccine, and almost 65% reported no use of any prevention. So, there is, okay. So the key takeaways of our study were that there is zero prevalence of HPV 16-18 in 9 to 14 years in Sindh. So this is a good target population for vaccination. There is a low knowledge of cervical cancer and HPV vaccine. This will impact the rollout program. There is high acceptability of vaccination if offered, and this is rooted in the reliance, trust, and acceptability of the EPI and the government programs. Also, educated mothers who possess better knowledge also have higher vaccine hesitancy. So simple awareness may not be enough, and we will need social behavioral change strategies. And in many ways, the audience in the front row, I am actually speaking to the to the experts here who already know that these are the challenges. Vaccine access was a main barrier, but with the rollout of the vaccine, it will, be less of a barrier. However, there is this question of reaching those 2 million girls or 2 million girls who are out of school. Female empowerment overall is low, and this will affect the ability to access vaccination, especially when we are seeking it out of schools. And also, there is an alarming burden of multiple type infections among female sex workers in Pakistan, with almost no awareness and negligible preventive practices. So this is a neglected, marginalized section of the population that we are still not focusing on, but which should be the target of the next immunization effort. I would like to acknowledge the huge GLOBE-HPV team in Pakistan, as well as at the International Vaccine Institute. And thank you very much for listening.
Thank you, Dr. Fyezah, for that comprehensive talk. Our next speaker is a senior advisor to the GLOBE-HPV project at the IVI International Vaccine Institute. Joining us virtually is Dr. Quamrun Nahar, with over 100 publications and extensive experience as the former head of research at ICDDRB in Bangladesh. Today, she will speak on barriers to HPV in LMICs. Over to you, Dr. Quamrun Nahar.
Can Am I audible?
Yes, Dr. Quamrun Nahar.
Yes.
You're muted now. We could hear before.
Now?
Yes, we can hear you.
Okay. Assalamu alaikum and good afternoon from Bangladesh. First of all, before I make my friend Dr. Muslima Ilyas for inviting me to join this program. It is an honor. However, at the same time, my apology for not being able to join physically. I'm out of Dhaka. I have internet connection, but it might go wrong anytime, and technology can fail. So my advance apology for that. The title of my today's talk: Barriers to Human Papillomavirus Vaccination in Low and Middle Income Country. Next, please. As you know, cervical cancer is the fourth most common cancer in women globally, and it is caused by infection by human papillomavirus. It is a preventable disease. That's the good part. However, and also HPV vaccination is a highly effective in preventing HPV infection. Unfortunately, introduction of HPV vaccine is not universal. Only 41% of LMIC countries have introduction of HPV vaccine compared to 60% of developed countries. There are some significant barriers in introducing HPV vaccine in LMIC countries. Bangladesh has introduced the vaccine in 2016, as a pilot demonstration project, which was later introduced nationally through a campaign program, and we made a commendable success in achieving the target at 90% around. While Bangladesh has made great strides, the journey was not without its challenges. Today, I will reflect not just on our success, but on the common barriers that many other LMIC face and how they can be addressed. Next, please. Let me now go through some major barriers faced by LMICs. You heard from Dr. Fyezah that how low the knowledge about HPV vaccine and HPV as a disease. So, and that is very common. That is limited knowledge about HPV, cervical cancer, and HPV vaccine is prevalent in many low and middle income countries. And that contribute to low uptake of services provided for cervical cancer, for screening, or even HPV vaccination. Studies in South Africa, Cameroon, India, and Bangladesh indicated that most women lack knowledge about HPV, its vaccine, and its association with cervical cancer. This limited knowledge and awareness may lead to widespread misconceptions and vaccination needs. In multiple LMIC contexts, rumors linking vaccines to infertility or premature sexual activity or causing certain diseases are very common. And these are barriers to vaccination uptake. Another significant barrier to HPV vaccination is financial constraints. Unless subsidized by the government, HPV vaccines are costly. High rates of hesitancy towards vaccine and reluctance to access essential health services also pose a significant challenge to the uptake of HPV vaccine. HPV vaccine hesitancy in several LMICs is exaggerated by misinformation and anti-vaccination campaign on social media. And many individuals, especially young people who are the target of this vaccine, are exposed to these misleading claims, which often deter them from seeking this vaccination. Religious and cultural beliefs often influence misconception surrounding immunization and screening. Unlike high-income countries like Australia or Scandinavian countries, which have successfully implemented a comprehensive cervical cancer prevention program, including an HPV vaccination initiative, many LMIC face significant government barriers. There is a lack of sufficient government support and commitment to implement comprehensive and sustainable HPV vaccination and cervical cancer screening programs in most LMICs. Many LMICs allocate inadequate budgets to healthcare, which can lead to shortage of essential supplies, including vaccines. Finally, the lack of political will or efficient policy implementation is another strong factor. Even when policies promoting HPV vaccination are in place, their implementation is often hampered by bureaucratic challenges and then lack of coordination between different departments and among health agencies. Next, please. Next, I will now briefly talk about Bangladesh's experience as a case study. We initiated this vaccination program in phased manner. First, started with demonstration project supported by Gavi in 2016 and 17. And it was done in one administrative district, and which gave us a 94% coverage, which is very good. However, it took us 7 years to convince Gavi and do all kind of coordination from the government level to ultimately have this national program. And this national program started in 2023 and also it completed in 2024. Again, it started as a pilot in one administrative division out of 8 divisions. And the lesson learned from this one division were addressed in the next phase when these rest divisions were covered. And then target population were multi-age cohort, 10 to 14 years old girls studying in grade 5 to 9. in educational institutions, including madrasa, and that was the primary strategy going through school, and that was supplemented through out of school effort from fixed site from health centers as well as satellite clinics. And then as a delivery strategy, we developed a registration app, VaxEPI, through which girls needed to register through their date of birth so that their age could be verified and the records are kept. And there was no additional paperwork so that when the information is entered, girls could have that printed vaccination card. So that was the advantage. And then, as I mentioned, this vaccination was offered through school as well as religious institution. School, religious school, that's what I meant. And the coverage was 89%. In fact, after the first phase, coverage was only 66%. And then there were a lot of problems, especially the target population and also religious institutions were not included in the first phase. And then all those efforts were made in the second phase. And then in the second phase, the coverage was 93%. So altogether, the national coverage is 89%. And now government is now planning to start routine immunization starting this year. But as you know, our country is going through some kind of political disturbance and the transitional government. So government is still hopeful, but let's see, it has not been started. But this immunization will be done through health facilities, not through school. So that would be a big challenge because these grade 5 school girls, they will be in school during school time, and how they come to the health facility, that would be a big challenge. So we need to wait for some time to see what happens. Next, please. So we face some challenges, and we also overcome those challenges. I have just put few challenges. For example, first was like eligibility and targeting. And as the vaccination was done through school, first the school authority provided some school enrollment data. But in reality, when these health workers went for vaccination, they found that this school list is overinflated because the schools were getting some kind of benefit based on the number of girls enrolled. And that gave rise to like a low vaccination coverage because this list was fake. So that kind of then these records were checked, and then in the next phase, which helped us like going with the actual list from the school, and the coverage was higher. Then the question came about consent. Parental consent, like the private schools, especially in urban area, they did not allow. Because they said like parental consent, we cannot like get the parental consent without just in a immediate notice. So we need to invite these parents. And for public school, what happened? School authorities send a letter to inform the parents, and that's the only thing they did in terms of the taking the consent. And then parents later, some parents were not very happy with because they were not informed. So that was the problem. Third one is rumor. TV rumor. In one case, I can mention where TV news where one girl in a school was fainted during vaccination, and after showing her fainted, 10 or 20 of her friends also fainted, and that was showing in the TV. And you know what it can what kind of effect it may have on the audience. And then to combat this problem, even the higher official from health ministry had to go to the place and then spoke to the people and then issued a special order clarification what happened. And that's how we managed. Next, please. There was a chance of vaccine misuse because it's a very expensive vaccine. So there were some kind of micro planning done on how many vaccine are released and how many were given. So that's how we managed. And then staff planning, teachers were included, school teachers along with health workers. And finally, I already mentioned access to religious school, who were excluded at the beginning, and then they were included. And they're included through engaging religious leaders, and that were very helpful. Next, please. So Bangladesh is now on the example. There are other countries. So I am sure my friends in Pakistan, you have reviewed those. So I will not go through, but Rwanda and Bhutan are two examples. And we can see what are the commonalities, what are the common preparation we have done to make this vaccination a success. Next, please. So if I summarize the strategy that is needed to overcome HPV vaccination, first is public awareness and community mobilization. That's a must. And then counter misinformation. There will be. But how to deal with that? You need to be prepared. Then free or subsidized vaccine, because we don't have that much money, but like Gavi and then other kind of support. And for Bangladesh, WHO and in UNICEF and Gavi, they provided path, they provided technical support. So that kind of support is needed. Then strengthen healthcare system. We need to train providers because they are not used to this kind of vaccines, and then engage multiple ministries. This is absolutely essential if you want to go through school, because in Bangladesh, school is under Ministry of Education, and there are two ministries. One is primary, one is secondary. And as I mentioned, the vaccine was given to grade 5 to grade 9. So that means it involves primary or secondary education, and health ministry and Ministry of Education, religious ministry, social welfare, all were involved. It's a mammoth task. And finally, male involvement. We need to educate men to support their wives and their children for vaccination. Next. So what are the take-home messages from a successful vaccination program? Pre-vaccination groundwork and community engagement. Second, culturally sensitive communication strategies so that there is more miscommunication. Third is gender-sensitive approaches. Fourth, investment in school health infrastructure. And finally, pilot testing followed by phased scaling so that the lesson learned can be adapted and can be refined, and mistakes made during the process can be corrected. Next. This is my final slide. So, but we have to remember that every context is different, but the success lies in this kind of endeavor is on preparation, people's commitments, and partnership. Let us come together to fight against the killer disease, cervical cancer, and save our women through prevention, screening, and treatment. Thank you very much.
Thank you, Dr. Quamrun Nahar. Next, we welcome Dr. Paul Bloem, joining remotely from WHO Geneva, Senior Technical Officer for the HPV vaccine. With over 2 decades at WHO, he also chairs the Gavi HPV subteam and supports global HPV norms, standards, and policies. Today, he will speak on HPV vaccine strategy. Over to you, Dr. Paul.
Thank you very much. It's a pleasure being with you. I'm trying to get the share function to work so that I can load my presentation. The host has to allow me. Yep, let me see now. It still isn't working from my side. Sorry for that. There we go. And there we go. Application, share, and now I hope you see this in full screen and that I'm projecting the right screen. So it's really a pleasure being with you. My name is Paul Bloem. I work at the World Health Organization and I'm the Global HPV Vaccine Impact Lead. I've had the pleasure both talking in a webinar organized by the Aga Khan University 2 years ago and being with the NITAC and the ministry in 2023 when the decisions were taken to introduce this vaccine. So I'm very glad we are at this point, extremely excited that we're so close to the introduction of this vaccine. And as you can see from the picture, many girls in Pakistan hopefully think the same. Vaccination is part of the elimination strategy, which has the different prongs of vaccination, screening, and treatment, of course, that together will have an enormous effect. We know the effect of the vaccination will be a long-term effect, but will then be the deepest effect. So it's extremely important that we get it right. And getting it right basically means reaching high coverage. It's only with high coverage that the vaccination has a big population impact, and we will look at that a bit. So my presentation follows nicely on the 2 earlier presentations. I think very important things about the barriers and the burden has been said, and I'll come back to just some of them. So let's start by where has this vaccine been introduced? Where are we now? And you can see from the bars here, particularly the green bar, which looks at the number of countries, we can see that we've now reached more than 149 countries actually today that have introduced the vaccine. This is 75% of the whole world. And soon we'll have more countries introducing. This year, what's projected is that Pakistan will introduce. I mentioned India and China. They are very large countries. And what's the effect of this? That's in the blue line. What you can see, so many countries have introduced, but many of them are relatively small countries. So today, we have 75% of the countries that introduced the vaccine, but it only covers around 45% of the population of global girls. And what may happen in 1 year is that that population coverage shoots up to 80% as well because of the large countries that introduce. Hence the importance of the introduction in these big countries, including your country. And that's why we hope the introduction in Pakistan will be a success. Here you can see also in terms of burden, there may be lower burden actually in China and also in India, which has an average burden. And Pakistan, we know, has a relatively low burden compared to the global average. But if you look at population size, all these 3 countries are very visible on this map. And so next year, when all these countries have introduced officially and they get a purple color because by then the vaccine is being given, we will see a very different distribution of the global burden that is protected by the vaccine. So in the first presentation by Dr. Fyezah, we heard about the burden of cervical cancer in Pakistan, a very important study that was being done indeed before the vaccine is introduced. So it's a very good to have that as a baseline as well. And she mentioned the different types of vaccine, of HPV types that we find in women with normal cytology, which is women found in the population and being tested. And also the women, the sex workers that we were working at were being tested, not because of problems that they were presenting with, but through a regular test. So what's the key point just to say is that when you test the population, the normal population with normal cytology, you find many different types. And 16 and 18 do not necessarily stand out. But please don't forget that that's not a sign of how oncogenic these types are, meaning what will be their contribution to the cancer cases. And what you see here is from the updated 2024 IARC global study. And it shows you that you find 16 and 18, the blue and the orange, very mild numbers in the normal population. But the moment you start to measure in low-grade lesions or invasive cervical cancer, the lowest bar, you can see that 16 and 18 across the world make up of around now 76% of all the invasive cancers. That's why 16 and 18 are so important. That's why a vaccine that is being introduced in Pakistan, the Secalin vaccine that protects against these two vaccines, has such an impact. You can see data specifically from the EMRO region where Pakistan is part of, and you can see from the Central Western Southern Asia. The modeling from IARC shows that up to 83% of cases can be protected with 16 and 18. And when in some years' time, the newer generation vaccines, which will have multiple types of HPV included, will be used, this can go up even a bit higher, up to 95. But at the moment, introducing and reaching high coverage with the current generation of vaccine will have an enormous impact. We talked about the safety of this vaccine. We heard there were some rumors, and we'll come back to that. But in general, just too important to say this is a very safe vaccine. There have been many rumors around this vaccine. That's why the Global Committee has over and over again looked at this vaccine. And every time the result was whatever is being said is not causally linked to the vaccine. Sometimes it's linked to vaccination. We'll come back to that, but not to the vaccine. The last review was done around infertility. Why? Because there's so many rumors about this vaccine may affect fertility. Actually, there is, again, the conclusion is no association between HPV vaccination and infertility. Actually, there are on some grounds to believe that being vaccinated may prevent some infections that can actually lower fertility. And so it could actually have a positive effect on fertility. So very good news on the safety front. In terms of what effect does it have in real life? Well, we heard about these Nordic countries with their good long-term programs and high coverage. Here, this is England. Indeed, they had high coverage, around 80, sometimes even 90%. What is quite astonishing is they used the bivalent vaccine, very similar to the vaccine being introduced in Pakistan, and they had 87% reduction in invasive cervical cancer. So we know the vaccine works, and the reduction is much higher, 87%, than one would think if you just look at the part of the cervical cancer cases that is being caused by 16 and 18, the types in those vaccines. At the time, it was thought that it would cause around 70%, and we have a higher protection than the 70%. This is due to a variety of reasons, but it really shows these vaccines are really good. It also shows this very strong age effect. And we heard that the girls in the younger ages have virtually 0, 16 and 18 cases. That's important. So vaccinating early, and nowadays we say, please vaccinate around 9 or 10. That's the best age for the routine cohort. You will have the full effect of the vaccine as it goes down over time. Is vaccination easy? No, it's not. Can it be done? Yes, it can. So you can see here that in high-income countries, but also in low-income countries, the lower part, we see a whole series of countries with very good coverages. We heard Bhutan, Rwanda, we have Malaysia, we now have Bangladesh. They're all in this higher part. They reach around 90%, 80%, 75%. But it's also true, and this is true in the high-income countries as much as in the lower-income countries, many countries have challenges reaching high coverage. Sometimes it's to do with confidence in the vaccine and hesitancy. We think it's in many places also a matter of how we plan for this vaccine and the fact that the planning should be really good. And we'll come back to that. So the first year of the vaccine, the campaign, very important. One strategy that the country already adopted is using a single dose. And this was done on the recommendation of SAGE and WHO that one dose provides sufficient and similar protection against cervical cancer than 2 doses do. And I show you this data, which is new data. It's very recent, several months old, actually. And it's from a large trial that compared 1 and 2 doses directly in the same trial. This was data we didn't have before. And actually, what you can see here is that it's amazingly similar, that 1 dose and 2 dose for both Cervarix, a 2-valent, and Gardasil, a 9-valent, we have the same protection, the same levels, and it's at a very high level. So this is super good news. And it's a strategy that helps many countries in many ways. We heard sustainability, funding is a problem. This part of the strategy is helping in that sense in many ways because we only have to go once. Very important in the full introduction, and we heard that, is listening to the community, understanding their concerns. We heard a presentation, the excellent presentation by Dr. Fyezah, that we have to know where they are in terms of knowledge of cervical cancer, of their trust on vaccination, and what any of misconceptions they may be, what the particular barriers are. So this is a slide I took from UNICEF, who is a key partner who helps on the front of communication. And this social listening is being done also in Pakistan at the moment by UNICEF and other partners, such as the presentation we just heard. And it all feeds in to this, the management, the communication strategies, to adopt them, to make sure it addresses the issues that are real in the local community. And all this to build, of course, vaccine confidence and to prevent hesitancy. So I take us to Nepal, who introduced now almost 6 months ago, on the 4th of February this year. Why do we go there? Well, partly because it was a good introduction, but also it used the Secalin vaccine, the same vaccine, and it was one of the first countries in the ASEAN outside of China where this vaccine was used at a large scale, and it has worked very well. There were no major AFI incidences reported, but I particularly want you to look at the graph below. They introduced the 4th of February, but if you look at their whole trajectory, they started long before, about 6 months in October the year before, with their social community listening, with the both online and offline, and working that into the whole strategy of communication to be ready on the 4th of February. So that whole preparation with a lot of emphasis on communication with many sectors, we heard that, is so key. So it's really, I put it here as an example of careful planning. And you can see also this country, very much like Bangladesh, had more than 90% national coverage. They used the 1 dose as well. So really this importance of the preparation. And once you reach your high coverage at introduction, the whole population will have heard about this vaccine, and it will be the good start for the years to come. Now, I was not aware that my colleague talking to me was from Bangladesh. So some of the things here are the same, but I'll highlight them slightly different. So we heard how successful the introduction in Bangladesh was, and it took place in different phases. Now, the interesting thing is Pakistan also introduces in phases. And the good thing is we can learn from phase 1, which is also in some of the provinces that are very motivated to go. And therefore, we can learn things there and apply them in other provinces, which may have more challenges or different kind of challenges. So I think it went very well. They used a campaign approach. We heard that. They used innovative strategies, the registration online. We heard a lot of lessons learned. Those are lessons we know from many places. We always have issues with denominators. We always have to learn how to do that. Consent and the fact that private schools do require written consent, even if the ministry says for the national level, it's not needed. So be prepared and help these schools to do their consent. We know about the rumors; they will always be there, and actually, they're mostly the same rumors. So prepare for it and be ready. Involving teachers in the planning, very important. And we often leave that out because of cost. At the last minute, it's too much cost, so we just do the health workers. But they are an important group to communicate with parents and to build that trust in the community. So these are some things. Now, I wanted to bring as a surprise fact. I have it covered here. It's not a full surprise because my colleague before alerted to it. Is not the fact that, of course, overall the coverage was extremely good with around 93% in the second phase, as we heard, but there was huge vaccine hesitancy in a way which was addressed for the first time during an immunization campaign. This was the way it was written by colleagues from the country. So what was this big event? Well, it was this event that's described here, and it was alluded to as a girl who fainted, and then others started to faint as well or getting sick. And before we knew, there were around 60 girls who in the end have been hospitalized in the hospital in Bola due to HPV vaccination. Now, two things about this. One is, this is quite common. There's actually nothing new about it. You go to the literature, you find that this happened on day 2 of the introduction, one of the first in the world, in Australia. It happened in the Netherlands. So in some of these countries, this event has affected very much, not only what happened in the country, but even what happened outside of the country. So, and there are countries that actually never recovered from these events and have low coverage since. And I could name a country, I won't do it. What's actually so surprising is all this happened, and the country decided that, rightfully so, this is an immunization stress-related response. That's the new term WHO uses for this. It used to be called mass psychogenic event. We've seen them happening over the actually last century with all kinds of vaccines, tetanus, polio, others. More often when you do vaccines of older age groups, not babies. So this is the type of vaccine where this can happen. The good thing is the country did exactly what it should do. It reacted rapidly. The minister came out and says, vaccine is safe. And that's the key lesson learned. And that's what the country in Pakistan should also do, were events like this to happen. So we developed a guide for dealing with these responses, and I put the reference here. So dealing with these responses, we know the rumors happen. It's about how you deal with them that tends to be the way that we respond. And of course, fainting is not a rumor, but it's something that we know can happen and normally happens a couple of times locally, but it may hit the news. So it all goes back to, the whole issue of communication. In that, of course, advocacy and coordination is so important. So I also took from the slide that I got from my colleagues how many groups have to be involved. And it's interesting to hear how we just learned involve many of the of the ministries. There are many more than you normally would do, including, of course, education, but also don't forget some of the sectors, such as the religious groups and foundations, etc. So I think there's many lessons learned. And so one of the issues is be open to the lessons that are learned in other countries and make sure to be open to apply them, because more often than not, we see they apply. I think one very important thing I want to mention is we heard that the country was talking about using the schools in the introduction campaign. And this is exactly what Pakistan will do. And in the second phase, when the funding will be a bit less from the outside, the plan is we'll adjust the routine and we'll deliver in the facilities. Now, to be honest, we do have, I have to go back, we do have seen quite some low and middle income countries go that route, and it will be a route of discovery. And some countries discovered that actually there is no habit of these girls, 9, 10 years old, coming to the facilities, and it's very hard to instill. So many countries in the end use HPV to start including schools as one of the regular outreach programs, and thereby, in a way, establishing a platform in the schools, which is exactly what we heard in the plea from the previous presentation, that investment in school health infrastructure, which is exactly what is actually needed to make sure HPV can be delivered year on year in the school, will be a very good societal investment for many interventions, not just this vaccine, other vaccine, but also other interventions that can be given to school-age girls and boys. So that will be a discovery for the second year, and Pakistan will not be alone. We heard it from Bangladesh, and I think we can learn across other countries as well. I'll go back to one of my last slides. This is from the European region, and this is a region where there are many countries with low coverage. Some do very well, some do not very well. What they are doing now, more or less almost 20 years after introducing in many of the vaccine, is working again on confidence. We heard how much trust, overall trust, both in governments, EPI programs, our vaccinators is important. So they're going back to the roots and say, okay, we did all the training at the time of introduction, but we actually have to go back. We have to go back to our vaccinators and do more training of the vaccinators. We'll learn them how to better communicate with parents and girls, but actually what they're also saying is we need to convince our vaccinators, our health workers, even more that this vaccine is good, and then they will transmit that confidence in the vaccine more easily to the population, to the communities, and the key stakeholders. So that training, and in this case, sometimes continuous training to reinforce and really instill confidence about this vaccine, can be key in many settings. With that, I want to thank you very much, and I wish, of course, not only a good event today, but the very good introduction next month in Pakistan. Thank you so much.
Thank you, Dr. Paul. We now have the honor of hearing from our chief guest of today's seminar, Mr. Rehan Iqbal Baloch, who serves as the Secretary of Health for the Government of Sindh. With a background as the former Secretary of Population Welfare Department and additional Secretary in the Education and Literacy Department, Mr. Baloch brings diverse experience to his role. Since his appointment as Secretary of Health in March of 2024, he has brought a strong focus on strategic governance and efficient healthcare delivery. His recent leadership includes spearheading Sindh's effort in the Big Catch-up immunization campaign, ensuring that children across the province, especially those who missed routine vaccinations during the pandemic, are reached with life-saving protection. We are extremely honored to have him here with us today. Please join me in extending a very warm welcome to Mr. Rehan.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, sorry I came late. I was stuck up and later in the traffic. On behalf of Health Department, I would let you know that the preparations for the coming HPV campaign is going on, and for that, the micro plans at the provincial levels are prepared, and for the district level, we are working on it. Even the training sessions are also going. We will see how our preparations are in, and we will finally decide whether we have to delay it a few weeks or not, keeping in view the preparations. The target is of around 4 million, out of which 50% are in school and 50% are outside school. Mostly the focus would be for girls from the age of 9 years to 14 years. And as far as the school coverage is concerned, we are in coordination and in contact with the school department, and we will be getting support from them also. And for the HPV vaccine, we have earmarked certain amount, around 200 plus million, and we are also having support from the Gavi and other partners also on the advocacy and other supports. We, in this case, I think we have to put more effort on the advocacy side, which I think still needs, especially on the parents' side, especially on the teachers, and especially other concerned persons to be informed well about what is HPV and what prevention we are going to have it. In this regard, the role of the pediatricians, the role of the gynecologists, and other stakeholders are also very important. While sitting over here, I went through a news clipping which was shared with my PS when I was on way. It was by Vakar Bhatti. He has reflected some of the gaps, but we will hopefully cover those gaps before the campaign starts. Thank you very much.
Thank you, Mr. Rehan. To present our gratitude for you and coming here to speak with us, I would like to invite Dr. Fyezah Jehan to present a bouquet of appreciation. Thank you. We now move on to session 2, where our focus shifts to addressing the cultural and social aspects of HPV and vaccination. We have Dr. Kausar Khan here from the Aga Khan University in IRD, who is a gender specialist and an anthropologist, a distinguished researcher in health equity and community medicine. Please join me in welcoming Dr. Kausar.
Assalamu alaikum, it's an honor to be here. And I would like to especially thank Muslima and the organizers for giving me this opportunity to talk. I've been in CHS for nearly 40 years. I retired recently, but I'm a visiting faculty here. And I find this an honor because I'm going to share some ideas. I'm not a doctor, I'm not a nurse. So I bring to the field of community health a different perspective, a perspective which is marginalized, but I personally believe, as a Chinese politician once said, see the periphery march to the center. So I find it's the people who have to march to the center. Since time is limited and we've had a very overwhelming session so far, I'll introduce just 3 points. One is, who are we in Pakistan? I'm focusing on Pakistan. And I find in Pakistan, we have 2 groups. On the one group belongs the researchers, the academicians, the senior bureaucrats, the very knowledgeable service providers. And these are the intellectuals like you and I who can talk very well. But on the other side of the spectrum are the people who are in the majority. And who are these people? They are the poor, they are the women, they are the minorities, they are the transgender, people with different sexual orientation, and they are the majority. And so there's this gap that exists between the better off people. We are all privileged, whether we like it or not, but we belong to the privileged class, which is in the minority, and the majority is outside. In Karachi, for instance, more than 50% of our population lives in the Kachi Abadis, where there's no water, there's no light, there's no secretary, and where we want to take the science to them. This section here is very science dominated, and I think the academia is science-based. I've taught paradigms, research paradigms for a long time, and in the paradigm of science, the knowledge is very important, but from the participatory action research paradigm, we say, where is it going? Where are the respondents? What is the ethics of not including them? The other point I want to make, so this is where we are. I work on an approach for community engagement, which is a power-based approach. It's a strength-based approach. And the first part of the cycle of learning is know yourself. Know yourself as a human being. When I interact with the poor, I don't interact for whatever expertise I may have collected, but as equal human beings. Now, the second point is, this is something I've been struggling with. Do we have a social norm? Do we have education as a social norm? A friend of mine who's an educationist, but is from Hunza, she said, Kausar, in Sindh, education is not a social norm. So I asked her, I said, you explain what you mean. He said, in Hunza, if in a village, a child is not in school, every villager can ask, why is the child not in school? In Sindh, when we go into a village, if the child is not in school, even the parents don't care, the neighbors, nobody cares. So you need different strategies to make education a social norm. Are women a social? What is the social norm for women? Subordination. What do the feminists say? Women are in a subordinate role, and even in the better off classes, if a woman is, the husband is the good one, is one who allows his wife to work. Very good. But when they both come back, the man will read a newspaper or watch TV, while the women will go into the kitchen to prepare tea. So in Sindh, Sindh is very good in taking the lead in laws, for instance. We have domestic violence law. But the women are killed in the name of honor. They are killed. The recent case of Shanti in Leari was killed because of marital rape. Marital rape is not a crime. So when we see the gender norms over here, they have not changed much. Of course, change is taking place and more girls are coming out, but we need to see what are the, because I quickly looked up HPV vaccination and what it does, and the girls are in the target, but I don't see women development department here. They are the ones who deal with women. They are the minister, I was talking to her, they deal with this horrendous cases that come to them. So the third point I would like to make is we say in social sciences, what is the nature of the problem? If the problem is a social problem, technical responses will not work or they will be limited. So I asked, is vaccine a social problem or a technical problem? The successes that we see in the work that has been undertaken are all technical issues. We do a lot of that. I think our advancement of the elite thinking of institution is in the science and the technical sides, but the social side is where it was. One indicator, we have learned to use LFAs, and we look at indicators, we look at processes, we do a lot of very good things. But the question is, what is our research paradigm? Where is the community? Finally, I would like to say that lament to me is not, I'm a human rights activist. I'm not, I'm part of human rights groups, and we take up cases like Shanti's case, where in 18 days, she went to 3 providers, but she was being taken around in a rickshaw. the family was scared of it being a police case. And so the mishaps within the health sector are a lot. An economist friend of mine said that, Kausar, in the world, we'll have health people internationally acclaimed from Pakistan, but we have a horrible health system. We have great economists who can rub shoulders with the economist of any country, but we have a horrible economic system. So what prevails is bad, but we don't end here. I think we have a lot of potential. Change is taking place. I always tell my students, write down your theory of change. How will change take place? Through experts or through people? I support the participatory action research paradigm, where community becomes partners with the scientists, but they're equal partners. They're not people to be pitied and said they don't lack awareness, so we'll give them awareness. No, no such thing. They have knowledge. I follow Paulo Freire, who gives a framework for social transformation. So we have to ask, as we move along, as science delivers, we also have to ask, what is it that people want? What is their dream of how they want to see the village, how they want to see the mohalla? And the social determinants of health, for me, from WHO, the 1978 Declaration of Primary Healthcare, and the social determinants of health, the 2008 report, tells you, improve the daily lives of people and health outcomes will improve within a generation. But nobody is working on that. But I think AKU has the potential to have a hub that looks at the pedagogies needed for community engagement, the theories that are available, and get into practice, not only theory. And I'm really glad that the government is here, because I think the government alone has the mandate. We can work on new ideas, but the government has the mandate to really take it forward. But in KP, I know there's work going on accountability of government providers, where the community is learning to hold them accountable, and the results are excellent. And I think there's a lot of work that can be done. And I'm sure AKU could take the lead in doing that. Create a hub. Pakistan doesn't have any institution focusing on community engagement, the participatory approaches in teaching and research. But this can be a new start. With that, I would like to thank you again for the opportunity to put my ideas across. Thank you.
Thank you, Dr. Kausar. Next, we have Dr. Elnur Ilyas Aliyev, Chief of Social and Behavior Change at UNICEF. In this role, he leads evidence-based strategies to advance positive health behaviors and community engagement across UNICEF's programs globally. He will be joining us online.
Can you please confirm if the screen is visible? I have shared my presentation.
Yes, it's visible.
So I'll be presenting on behalf of Elnur. My name is Shafi. I am the Social and Behavior Change Specialist with UNICEF Pakistan. And in today's presentation, we will focus on the key social and behavioral insights that UNICEF and Jhpiego has produced for the HPV vaccine introduction, which has informed the development of the HPV SBC strategy, which was nationally endorsed, and also the key approaches that needs to be undertaken both for the SBC and also for the delivery of the vaccine as well. Just a second. So I'll first quote some of the key findings from the Jhpiego's CAP study that was conducted earlier this year. So if you look at the overall awareness around cervical cancer, HPV and HPV vaccine, we came to know that the level of awareness of cervical cancer is only at 17.2%, whereas there is only a 4.4% of caregivers they have heard about the virus or infection called HPV. So the awareness is pretty much low when it comes to knowledge about HPV virus. And then there's only 2.9% of caregivers that are aware that there is an HPV vaccine which can prevent cancer vaccine, which can prevent HPV and cervical cancer. So this is the level of information and awareness that we have currently around the country. It was a national survey conducted across the country where more than 4,000 respondents were engaged. Some of the knowledge, the knowledge of transmission among those who had heard of HPV, they were a mix of various transmission modes that were that came out as a result of this study. The most common and the highest was the sexual transmission, but there was also blood transfusion where people said that the reason for or the mode of transmission for the HPV is
Dr. Vikas,
yes, can
can
you
you
hear me?
please switch to the slideshow mode so that we can view your slides better?
Can you see now? I thought I had displayed already. Is it fine?
No, it's still not in the slideshow mode.
Just a second.
Yeah. I think you should continue with your presentation. Dr. Vikas, please continue with your presentation.
Are my slides visible? Actually, I cannot see them on my screen anymore.
Yes, we can see your slides.
Is it full screen now?
Yes, it is. Thank you.
All right. Just give me a second, please. I'm having some issue with the system right now. I'm so sorry for this. Can you confirm if you can see my screen?
We can see it now.
All right.
Sir Vikas, we are sharing your screen from our side. You can say next to us.
Yeah, can you please go to slide 4, please? I'm so sorry. It's my system has frozen actually. So if you can go to slide 4. Thank you so much for this. Can we go to the next slide?
Is this, sir?
We can't really hear you. Do you think it's okay if we can come back to your talk in 10 minutes? Should we switch? Okay. I don't.
Am I audible now?
I can hear you. I don't know.
Is Dr. Elnur online? I know, I'm asking about Dr. Elnur because our next speaker is Dr. Elnur, and I think that in the interest of time, we should move. Unfortunately, these are technological issues and...
Am I audible?
Oh, yes, you are. Hello, Dr. Elnur. Sorry to keep you waiting. Can you hear us?
Actually, we have a issue of in the office. We have an issue of the mic. Am I audible?
We can hear you. Can you hear us?
Now I can hear you. Can you go back to the slides?
Excuse me, ऊपर मैं आप लोग को कह रही हूँ कि डॉक्टर एलनूर की प्रेजेंटेशन लगा दें प्लीज.
Good afternoon, colleagues.
It's the same presentation.
It is, yes, it is same presentation. I was in the meeting.
Oh, thank you so much, Dr. Noor. Okay.
So Vagas Shafi, he's my colleague who's been managing and leading the SPC Insight for HPV vaccine introduction. Can we go to the slide number 4? In the best interest of the time. Yes. So overall, the studies indicates that the fears and concerns about HPV vaccine, it is mainly in relation with the limited or lack of knowledge and awareness on HPV and its different levels of interpretation, its implications overall. For instance, 37% were concerned about the safety and efficacy, while 19% saying that the child was afraid of the needles. So this is the very the leading this kind of the concerns leading to the misconceptions and misperceptions about the efficacy of HPV vaccine. Can we go to the next slide? In the next slides, this is led by UNICEF Social and Behavioral Change Team, where we generated the insights, behavioral insights through the co-creation, the interventions as well. And I would like to highlight those that creates and contributes to the overall myth and misconceptions. One is already mentioned, HPV awareness is critically role. Another one, it's about the fear of cancer is strong motivator. For instance, once you mention cancer, I'm scared now. But that misconceptions about the hygiene and the prevalent fatalistic beliefs are major hindrances to acceptance. And one of the another element that I believe it's been also mentioned in the previous the discussions, and you already touched upon that gender dynamics in healthcare decision making, which is not only in relation to the HPV but also in relation to the routine immunization, vaccination efforts as well, because the women, they are not the primary decision makers, and due to their level of education, level of the literacy, it affects to the scale and the scope of their belief to the vaccination, and they can be associated with other vaccinations as well. Can we go to the next slide? In the next slide, we would like to share the co-creation insights for vaccine introduction, which also guided, next slide, which also guided the provincial SPC demand generation, advocacy, social mobilization plans in partnership with the provincial API teams. So one of the things, injection versus vaccines, it's a matter of the psychology of which terminology we are using and what is the connotative meaning of these words in our mindset that enables us or hinders us to make the decision. So for adolescent girls, the overall, the insight, the vaccine evokes hopes and prevention. whereas injection evokes fear, needles, and past illnesses, which is injection, it's a connotative meaning most likely regarding the fear and concern about that. And the goals speak future, not fear. These are the things also comes across the mainly the addressing the gender dynamics in that, because the HPV in the context of Pakistan, from gender dynamics, it is complex, and our co-creation interventions enabled us to better understand the girl child and her enabling environment to deal with. How can we create that enabling environment for them to move further? That's why they want respect. Health communication must stop treating girls as a vulnerable objects and start presenting them as aspirational subject. For instance, treating girls as vulnerable object, it is the result and implications of the gender dynamics in social and behavioral change interventions, among other service delivery interventions as well. Can we go to the next slide? In the next slide, you will mainly, I would like to take your attention to the two key areas. One of the also it's related with the linguistics, it's social linguistics, and also visual semiotics. How the people react, reflect when they see the image, which will mainly promote the adoption, acceptance, recognition, the positive aspects of the HPV vaccination rather than injection. For visuals to resonate, the participants of the co-creation, the beneficiaries, and the primary, secondary, and tertiary participants group, they mentioned that they must reflect the community, not idealize the version of it. So meaning that we need HPV vaccination is the subject for the girl child's health, but also is a subject for community to take care of a girl child to be healthy and released from the cancer. Another also gatekeepers of the consent, they mentioned about the mother in response to enable and empower the mother to be more empowered with a more decision making, and also they want to stake in their daughters the health and overall families the being, because if we consider the gender dynamics in the context of the communities in Pakistan, we will see that the frequency of communication and interaction and discussion points is very high between mother and daughter, which means that mother better positioned to understand the perspectives of daughter, and which means that the mother will be the key to dispel the misconceptions and common myths around the HPV vaccine. Can we go to the next slide? In the next slide, of course, we don't forget about the fathers, where the most fathers were not involved to day-to-day health decisions, but their passive approval could easily stall the campaign. They don't want details about the female reproductive health or anatomy. They want clarity and legitimacy. That is very clear, and that's why we highlighted that they want clarity and legitimacy. And the trust engendered and embodied, trust is not a message, it's a face. It's a face of our every single action that we are building upon. And for girls and the mothers, lady health workers are trusted not because of their job titles, but because of their showing up, because they're demonstrating the dedication and commitment, because they're only the professional who are able and capable to dispel the misperceptions, who are empowering and taking an action toward the promotion of any vaccine, and especially HPV vaccine. And I would like to highlight the key areas that the lady health workers, they are not only to be engaged in HPV vaccine, but they have a years and wealth of experience dealing with the myths and misconceptions. And they are the capable to listen. They belong to those describing the trusted teachers and women in white coats, symbols of safety and intellect. Can we go to the next slide? So in the next slide, we do understand that the campaign will be happening at the school level. And all our beneficiaries of HPV vaccination drive, they will be school children. And schools vaccination during the class time, and especially in co-ed settings, to some extent, may provoke the shame. And girls feared public exposure in front of the boys, and highlighting the need for privacy, gender sensitivity, and safe emotional environments in adolescents' health interventions. And again, the gender dynamics is coming very strongly here. And again, the emotional environment may affect to lead to some extent to some extent hesitancy to uptake the vaccine if it's not meeting their privacy. After school vaccination feels safer but can spark suspicious. This is also kind of, the both items, they are subject to the myths and misconceptions and the myths and misconceptions. So trusted community spaces like BIFAC offer socially endorsed alternatives. These are also to some extent what we observe that in one area it may not be relevant in other areas. And utilizing culturally familiar setting for vaccination may reduce stigma, increase uptake, and honor local rhythms. But again, it is a subject for the scale, scope, power dynamics while we are designing or implementing the SBC, social and behavioral change interventions for HPV vaccine introduction. Meaning that the location may play a critical role, if not so, to either to address the misconceptions or to create the misperceptions around the HPV vaccine. Next slide. So in the next slide, reaffirming the risk. In social and behavioral change, we have the risk communication and community engagement we used to expose during the COVID times. And in the context of risk, we are talking about the from fear to fertility. And our behavioral insights mentioning that a powerful reaffirming came from the lady health workers themselves, where they made a statement. Don't say vaccine causes infertility, say it prevents cancer that causes infertility. So that's again the way we are delivering the messages. It may create the misconceptions, and it may dispel the misconceptions, and that is that is possible as much. That is only possible to dispel the misinformation, misperceptions, misconceptions, as long as we have proper knowledge and understanding and awareness about the HPV. In the last one, I would like, before going to the recommendations, collective behavior is the most powerful motivator in social proof. The campaign's success depends on the sense of collective movement and shared responsibility. And that is the reason why social and behavioral change interventions will have to focus on the unified efforts driven by the school-based and community linkages, connections at the community level. Next slide. So in the key recommendations, I would like to highlight not all of them, not repeat them, but I would like to mention those the risks that may create the misconceptions and misperceptions around HPV vaccine. The one of them is to reduce the risks using the localized cultural resonate visuals that reflecting families and communities, avoid polished or urban imagery that feels alienating, or emphasizing girls' future and aspirations rather than fear or vulnerability in messaging, and call for actions with a focus on hope, strength, and agency. And expanding beyond traditional forms of communications using the digital platforms wisely. Next slide, please. Here, the frontline workers will be playing very critical role, and especially applying the interpersonal communication tools and helping them addressing the common rumors and concerns. And on top of that, engaging boys through the school and community-based platforms may build supportive attitudes toward HPV vaccination for girls. And of course, engaging the key influencers, opinion leaders, which will create the enabling environment for collective behavior to support the HPV vaccination. Next slide. I would like to thank Aga Khan University and first accept our apologies for the technical glitches that we were not able to cover all the aspects that's expected from us. As UNICEF Social and Behavioral Change Team, we wish you the success in HPV introduction, and I do believe UNICEF team members also attending, and they will be contributing and supporting the HPV vaccine introduction in your province. Thank you very much. All the best. Bahut shukriya.
Thank you, Dr. Elnur. Now we move on to the much-awaited segment of our seminar, the panel discussion. Our panel will be moderated by Dr. Muslima Ijaz, whom I would like to invite on stage. I would also like to invite all of our esteemed panelists to please take their seats on stage. We have Dr. Raj Kumar, Project Director, EPI Sindh. Dr. Khalid Shafi, Chair of NITAC, National Immunization Technical Advisory Group. Dr. Sharaf Ali Shah, Executive Director, Bridge Consultants Foundation. Dr. Afshai Sanif, Senior WHO Consultant for HPV. Dr. Qurban Bhutto, Deputy Director of Private Schools of Sindh. Dr. Alia Begum Aziz, Associate Professor of OBGYN at AKU. And Ms. Samiha Ashfaq, an A-level student from KGS who works with youth volunteers.
Thank you so much, panelists, to be here with us. To this panel discussion, whose title is The Readiness and the Realities for HPV Vaccine Rollout in Pakistan. So together we are going to explore the readiness of the health system and the realities from the communities. So, sir, to start with, without any delay, because we are already late, let's start the stage for the program from the program perspective before we go deeper into the scientific and the community or the implementation aspects. I'll start with Dr. Raj Kumar, since I'm starting with the readiness thing. Sir, given the competing priorities with EPI, how is the program ensuring readiness, i.e. the logistics, the workforce, and the financing for the introduction of HPV vaccine?
Thank you, Dr. Muslima.
as the technical part all has discussion has done. So how we can operationalize regarding the modalities about the campaign. So it's our top priority. So it's the history going to be created from our side. Sindh has taken the initiative, the first one, who has done the promises that we can celebrate as just like that date was the 15th September. So all the preparation modalities are going on. Regarding the, just like our Honorable Secretary says, the target set was the 4.1 million. So the all the, just like a school, we have the 20 million registration there, 9 to 14, and 9 to 14, 20 million out of the school. So all the registration with the school, partnership with the private, public sector, if we will see in the Karachi sector and rest of the Sindh districts, we have somewhat the challenges, just like Karachi school registration is more than 70%. So we will cover 70% in the schools, rest of 30% in the out of the school. So all the micro preparation is going on, training sessions are going on, all the workforce. So all as a team member, 4 members will be in the team. So all neighborhood UC level micro plan is undergoing on the preparation side. So training is going on. We have the lot of experiences, the previous campaigns, measles campaign, typhoid vaccination campaign, polio campaign. So works forces mostly engage how to operationalize these campaign more. So all preparation is going on. So one skilled person will be the lead side of that team who has know about the vaccination, injection. One will be the on the registration side. Two will be the social mobilizer. So they can go in the community and just be the knock the door, and they're targeted what's the target in that house, how much girls 9 to 14. So they will motivate and bring them to the outreach sessions where they can be just establish these sessions. So our Madam Minister's vision is clear. So from 15th September, inshallah, we will be on the
In the
campaign
field,
side.
yes. Thank you, sir. So this is about the operational readiness. We know that readiness alone needs, it's not enough. So, sir, coming to Dr. Khalid Shafi, what were the key scientific and the policy considerations that led NITAG to recommend the introduction of HPV vaccine in Pakistan?
An accepted international standards how a vaccine is recommended in the national program. And it's actually the country's own requirement and keeping the view of the global trends and the SAGE recommendations. Now, first the SAGE recommendation, then the RITAG, and then comes the NITAG. And for there are number of vaccines which are waiting to be included in the national program. In Pakistan, we have a special situation. We have a very good vaccine, the pediatric age group, and for the pregnant ladies, but the coverage is reasonably low. So the first priority and the first demand from all the sectors is that one we should first increase our coverage with the current vaccine, and then we should increase some new vaccine. So there was a lot of controversy about introducing a new vaccine, and it was a real challenge for the NITAG to consider a new vaccine. But we cannot keep ourselves away from the world trends. And the whole world is going towards a life course vaccination. And we cannot keep limited our program till 2 years of age or till only the pregnant ladies. And similarly, these adolescent girls and which will going with the females of the future have some rights. So this vaccine was considered to be included in the national program, but the first consideration, it was in principle approved that it is required, but there is a procedure which is called the ETR, evidence to recommendation. Weak evidences were present from our data. It's not that the disease may not be present in the Pakistan, but there's dearth of data about it. So the vaccine consideration was deferred for the next 6 months, and the data was again collected, then individual efforts were done, and different institutions are written letters, some of them responded, some of them, then some data was collected. So standardized data, projected data, these tools were, which are internationally accepted tools, they were used. And ultimately, we choose a vaccine which is very compatible with the attitude of our people, that is a single dose vaccine, a safe vaccine, and other things were also, which I don't want to mention everything here, were also considered. And we approved this vaccine. And the NITEC did not only approve this vaccine, the NITEC also recommended, number one, inclusion of this vaccine in the national program. Number two, screening and the treatment facilities also, because just introducing a vaccine to control an infectious disease is not sufficient. We have seen the prevention, we have very good vaccine, but the other factors which are also associated with the disease control, like the typhoid vaccine, other vaccines, are not so much given importance. So the NITEC is especially emphasized. Whenever I'm going in these days, I am telling the government people, the one recommendation you are following, you're not trying to follow the other two recommendations, that improve your screening facilities and the treatment facilities, which are not up to the mark at the present. Thank you.
Thank you, sir. So science is clear and policy direction is set, but policies only work when communities accept. So Dr. Sharaf, how can NGOs be better engaged in community mobilization and demand generation to ensure the equitable access to HPV vaccinations, especially girls who are out of school?
You are very right. Actually, vaccination against a sexually transmitted infection is very, very challenging, and particularly society like ours. So engagement of the community or community mobilization is must. And community mobilization you cannot get without involvement of NGOs. NGOs who are working with the community level, they have to be involved. And I think government of Sindh has done commendable job that they have included NGOs in the technical working group. So I think this is the best thing to involve the NGOs. And there are a lot of misconceptions, lot of misunderstanding about the disease.
Yes.
So to address this issue, NGOs can play the vital role.
Yes.
And then again, advocacy NGOs can do with the government, with the community leaders, involving the community leaders, involving the religious leaders, involving the women activists, human rights activists, so this can be achieved through the involvement of
society organizations.
So NGO will play a very important and crucial role in the vaccination, especially vaccination against the HPV infection.
Perfect, sir. Thank you so much. So that brings us to the broader global and equity perspectives. Now, from WHO experience, Afshan, how can countries like Pakistan strengthen HPV vaccine introduction and scale up efforts while ensuring equity, especially for out-of-the-school girls and the underserved populations?
Thank you so much, first of all. I think what a fantastic session it has been, and fantastic speakers, a much needed session when it comes to advocacy, awareness among the healthcare, and I can see very young, enthusiastic persons listening to us very vigilantly, to the very senior professors and professionals. I think it is so important to bring the necessary awareness, and coming to your point and perspective, bringing equity to the undeserved, just adding to what Dr. Raj said, that Pakistan, if we talk about that, we have around 17 million young women. And if we talk of the province of Sindh, there are approximately 4 million girls. That is the target population for the HPV vaccine. Interestingly, as opposed to the rest of the country, half of them are out of school girls. So to address that area, the government has made a very comprehensive strategy, because I hope many of you might not be knowing, but this HPV vaccine was spearheaded by the Minister of Health from the Sindh province when she first wrote a letter to Gavi. And that's how the whole process initiated. And today we stand here expecting the first phase of the national HPV rollout in Pakistan. And in the first phase, we have Sindh, Punjab, ICT, and Islamabad as part of that. For the out-of-reach school girls, basically, they'll not only be the fixed sites, but also an outreach component and the specialized mobile teams. And with the government of with the government of Sindh, there are also allied partners who will be supporting this outreach activities, and with the help of necessary awareness, I think it will be, hopefully it will be taken care of. But like many of them said, that awareness is one of the backbone of a strong campaign. So a lot is needed. So with the help of partners, the community organizations and academia like Aga Khan, I think this campaign would definitely, which is very much on path and would be a good success, and we'll be able to have the necessary coverage required to cover these girls, especially the 2 million out of school girls. And for the next part, the next part of the question is also how to provide equity. I think one of the key stakeholders are also the parents. So with our partners, some of the advocacy sessions for the parents, for the healthcares, they have also been organized and are also in process. So that will really cement and pave the way for improving upon the acceptance for vaccine awareness, and also the acceptance to bring in the girls to get them vaccinated. So I think with the help of the government and you all, it will be a good campaign in first
Inshallah.
phase. Yes, inshallah.
Okay, so equity also depends on the platform we use.
Yes.
So Bhutto Saab, what is the role of schools in supporting the rollout of the HPV vaccine, and how can we ensure that both teachers and parents are adequately informed and engaged?
अस्सलाम वालेकुम मैडम, पहले तो मैडम हमारी रफ़िया जावेद यहाँ इनवाइटेड थी, तो मैडम बिज़ी थी तो मैं आ गया। अच्छा, एक्चुअली आप देख रही हैं कि तमाम जो बच्चियाँ हैं वो हमारे ये जो एज ग्रुप है 9 to 14 ईयर्स, ये स्कूल्स में बच्चे हैं। मैं एक्चुअली प्राइवेट स्कूल की बात करूँगा तो हमारे पास 7,80,000 अराउंड बच्चियाँ हैं जो इस ग्रुप में आती हैं। हमारी पहले दिन से कोऑर्डिनेशन रही है डिपार्टमेंट से, हेल्थ से, और मैं इनको अप्रिशिएट भी करूंगा कि इनकी टीम्स हमारे स्कूल में जा रही हैं और वहाँ से डेटा कलेक्ट कर रही हैं। हमने तमाम स्कूल्स को सर्कुलर्स इशू कर दिए हैं, हमने डिस्ट्रिक्ट फोकल पर्सन नॉमिनेट कर दिए हैं। जहाँ जहाँ भी इश्यूज़ आते हैं हेल्थ डिपार्टमेंट को डेटा के हवाले से, तो हम इनको फैसिलिटेट कर रहे हैं। और हम वहाँ व्हाट्सएप ग्रुप है हमारे तमाम स्कूलों के, फेसबुक पेजेस पे, और वीडियोस आज भी मैंने डॉक्टर सायरा से शेयर की है। मैडम रफ़िया ने स्पेशली HPV वैक्सीनेशन के लिए एक वीडियो बनाई है, वो हम सर्कुलेट करते हैं तमाम ग्रुप्स में। तो ये तमाम काम हम कर रहे हैं, और जो होगा इंशाल्लाह हम उसमें सपोर्ट करेंगे।
Okay, so far we have talked about the access and engagement, but we also need to address the misconceptions that can undermine confidence. So from a clinical perspective, Dr. Alia, what are the most common misconceptions you encounter among women and girls regarding HPV and cervical cancer, and how can healthcare providers address them effectively?
Thank you, Dr. Muslima. There are so many misconceptions that I will try to address the most common three. The first one, which is most common among the not only the people but also among the healthcare providers, is that cervical cancer is a rare disease, so why we are spending so much money on its prevention. Now, as Dr. Fyezah Jehan has presented the figures, that every year 5,000 women are being affected, and out of those 3,000 die of disease. And I, as a clinician, have seen the plight of those women who are dying of the disease. And it's not those 3,000 women, these are 3,000 families and 3,000 children who are being affected by this. So we have to intensify the efforts in educating the public that it is a very common disease. It is after breast and oral cavity cancer among women, it is the third most common cancer in Pakistani women. And in the age group of 15 to 40, it is the second most common. So that notion that is very rare, it's not true, right? The second misconception is that it is attributable to hygiene, poor hygiene, and evil eye, right? वो बुरी नज़र से हो जाती है. So that's also a misconception. It is just the persistence of high-grade HPV viruses which are causing this. It's nothing, it's not related to poor hygiene, and this misconception has to be clarified, that it's not because of evil eye or some superstitions, it is because of some virus, right? The third most common thing which we hear among our elite group is that it is because of it is more common with women with multiple partners or partners with multiple partners. So because I'm in a monogamous relationship, I don't have the risk of it. So why me or my children should go for this vaccine? So we have to clarify that this is a very common virus which can be transmitted through even a single sexual sexual activity, and it can affect even in a monogamous relationship. So it's not that it's not classified into very high risk group. It can happen with anybody, and that's why our daughters have to be prevented. So the other most common, the fourth one, is that it causes infertility. And as we just heard in the lecture, in the talk by Dr. Elnur, that we have to clarify that it is a very safe vaccine. It doesn't cause infertility. In fact, it prevents the cancer which causes infertility. So as a clinician, I've been seeing young people who are being affected by cervical cancer or by pre-invasive disease, and now they are infertile, and they are worried about their reproductive status. So we have to protect them, right? So these are the four most common ones.
Thank you, Dr. Alia. So communication is not just top down. Young people are often the best messengers to their peers. Samia, the youth representative, to what extent should adolescent girls or youth organizations be involved in designing the communication strategies?
First of all, I'd like to say thank you so much. I'm honored to be here as a youth representative.
Thank you.
And I think it's very important to empower adolescent girls to be more involved. As mentioned, cervical cancer is entirely preventable, but it's preventable if the vaccination is given to that target group of 9 to 14-year-olds, of adolescents. And they need to be part of that communication. They need to be part of that discussion, because it's their issues that we need to address, whether it's knowledge gaps or whether it's understanding their decision-making dynamics. And as mentioned earlier, fathers have a key role in decision-making. So it's very important to make fathers aware of the risks of not getting their daughters vaccinated and of providing accurate information to them about the vaccine. And I'd like to talk about some of the social work that I've done in the Ibrahim Hedri community. And I think Dr. Fyezah was mentioning that as well, that we worked with youth volunteers over there for key issues such as thalassemia, such as malnutrition, and having youth volunteers to spread awareness proved to be very effective. So I think it's very, very important to empower our girls to be a part of that communication. Thank you.
Thank you, Samia. Thank you so much. So we have explored the readiness, policy rationale, community engagement, equity considerations for HPV vaccine introduction. Now I would like to go a little deeper, focusing on barriers, the cultural sensitivities and the practical strategies that will make the rollout both effective and equitable. So coming back to Dr. Raj, how is the program addressing gender-based barriers to HPV vaccine access, especially in conservative or rural areas?
Thank you. That's the man, just like a 9 to 14 and adolescent girl, the concept about the vaccination. So that's the challenge as the high socioeconomic belt and the rural side. So we are going to how we can address this. So we are find out that the trust building among the community with the LHW, with the community leaders. Just Dr. Sharaf said that the NGOs, they are the just like in the community doing the lot of social work. So we are engaging the policies as compared to the Karachi high socioeconomic belt, rural area. So there are the different one, how we can address that one. They are so much silent, they doesn't know about the disease burden. So how we can address this? That's the challenging. So how we can just like these girls to be reach outside with the outreach centers, the tradition, taboos, how they can be vaccinated, these girls, these are the challenges. So we are engaging multiple stakeholders among the rural side, how we can motivate them, just like in Tharparkar nowadays. That was the seminar. All political lead was on the uh, that was the on board. So everyone address among their agenda was another, but the HP was the top priority. So all political leaders with the social sector leaders were there on board. So they have, just like in all Tharparkar, 60-70% audience will be the rural side, these communities. So they have given these details how HPV is important. So multiple engagement sessions we are doing. So inshallah, we will cover much more than the target.
Yeah, hope for the best, inshallah. Dr. Raj has highlighted the program's approach to overcoming gender-based barriers, particularly in the rural and the conservative areas. But these strategies need to be rooted in evidence and sensitive to our cultural realities. Dr. Khalid, how does NITAG ensure that its recommendations reflect both global evidence and local context, especially cultural sensitivities around the adolescent girls' health?
Whenever a disease is considered to be included in the national program, the acceptability is one of the main criterias. Because if the community do not accept, it will not help.
Yeah.
So this aspect was considered in detail. And the example of the neighboring countries, especially the Islamic countries, which have a similar culture, different culture, but the similar values like us, like Saudi Arabia, other countries were considered. And the countries which have included the vaccine in their national program, their coverage rate is 90% plus. The only problem in Pakistan, which we are afraid of, that is certain myths, which even are attached with the polio program for the last 30, 40 years. And some of the so-called not the truly religious, false religious things, which may someone provoke. This step was taken into account. So it was decided by that NITAG that the word sexual activity related things will not be used at all for this vaccine. And for example, this typhoid vaccine, some people are saying, people may Google and see what is the type of the disease, how it spreads. Our people do not, when we talk about the typhoid, they never Google how the typhoid spreads. So now all the intelligence will come here for this time. One thing is that. And the other thing is that it prevents the cancer. Like we have another vaccine, hepatitis, which prevents the cancer. Yeah. And there is different etiology of cancer, different types of cancer. So we must be very careful while counseling and convincing this vaccine that our communication should be in line of our cultural values.
Yeah, exactly.
So we should stress about that, but cancer itself is sufficient. If we are able to convey that it will prevent the cancer in the female. Female, what does a female mean? Female means my daughter, my wife,
exactly,
my mother. No, something else is not the female. The females are my part of the family, everyone body part of the family. Who will not like their females of the house, their daughters not to be protected against this, if we convey the right message? Thank you.
So we have heard about aligning science with the local context. And now let's talk about putting that into action on the ground, Dr. Sharaf. What coordination mechanisms between the government and the civil society, and that includes the NGOs, can best address the misinformation, build trust, ensure that HPV vaccination rollout remains inclusive, gender sensitive, and responsive to the community voices?
Yes, you were talking about the barriers. The biggest barrier, what I see in the vaccination of against HPV, is the nature of the disease itself. When you talk to the community that we are protecting you against a sexually transmitted infection, you are girls. So this is very difficult to say.
Yes.
When you say you have to use culturally and socially acceptable terminology to make understand, then you have to develop trust.
Exactly.
The community. If there's no trust, then it's very difficult. I think to develop trust, it's very necessary to involve the general practitioner in this vaccination program, because general practitioner enjoys the trust of the community, is easily accessible, easily affordable, and then people listen to him.
Yeah.
So I think through NGOs, general practitioner can be involved, and general practitioner can take the because they have confidence, people have confidence in them, and
Okay.
they can convince the people and explain the situation, the hazards of the HPV infection, and how it can be protected.
The point to be noted, Sunil, by Dr. Sharaf. So that brings us the role of global guidance in addressing these very challenges, Afsha. What WHO recommended strategies can be used to counter vaccine hesitancy in culturally or religiously sensitive settings? And linked to that, how can we adapt our monitoring and evaluation systems so that we only track coverage, but not only track coverage, but also spot and address bottlenecks?
Okay, so I'll divide your question
Yeah,
into
into two.
parts.
Yes.
So starting from so if we talk like it's a beautiful August gathering, vaccine hesitancy is a real thing.
Yes, this is
So
reality.
absolutely, when we are discussing this, basically WHO and all the healthcare providers, we do believe that it starts at all levels. Dr. Raj rightly mentioned that when we had an advocacy seminar, we include the top political leadership. We took the top to bottom approach. But when we talk about top to bottom approach, we not only should talk about the commitment, political commitment, we also should talk about the different tiers like the healthcare providers, the education, the teachers, champions, the community leaders. And when we talk about the religious hesitancy, we should talk about the religious leaders. Now, we know in Pakistan, the prevalent religion is Islam, and then followed by other religions. So the inclusion of all religious leaders, when we say from all the different religions, I think it's important and imperative. And like very rightly said by Dr. Kausar, that participatory approach, when we talk about the problems faced by cervical cancer, and like when Dr. Alia said that she has seen the plight of patients, the women walking in with that cancer. If that could be shared with these religious leaders, the teachers, champions, I think we have the best voices and a sustainable voice that once, even when the campaign is over, they can be a constant source of inspiring young girls and parents and the community to bring in their children for routine immunization. It should not be stopping at the campaign level. It should be going beyond that. It should be a sustainable, it should be an ongoing part system that we should be building upon, we should be thinking upon, and we should be working towards. And as of today, when I see different tiers of academia and community health workers, our senior healthcare professionals, what is the common point? That we want to bring in a sustainable effort to improve awareness at all tiers. So WHO encourages not only the planning, not only the execution, the technical support, but also the very backbone of any campaign, that is a good advocacy, good awareness, and to bring the sustainable leaders, the sustainable champions who can talk about these talks, which are so preventable. And last point that Dr. Shafi said, that this is the second only vaccine that can prevent cancer. So I think that should be one of the taglines that we can really use, that there are very few strategies that can be used to prevent cancer, and Secalin or the cervical cancer vaccine is one of them. Thank you.
So this is, the global strategies. Let us turn back to the critical delivery platform, sir. How can we address parental concerns and misconceptions within school settings to ensure the higher acceptance and uptake of HPV vaccine among girls?
एक्चुअली मैडम मेरी सजेशंस ये है कि सर्वाइकल कैंसर और पोलियो, कोविड-19 इनको हम करिकुलम का हिस्सा बनाएं, और ये जो रिकमेंडेशंस है वो हेल्थ डिपार्टमेंट, एजुकेशन डिपार्टमेंट को भेजे, ताकि देखें अगर हमारे टीचर्स वो ट्रेंड नहीं होंगे, उनको पता ही खुद को ही नहीं है कि सर्वाइकल कैंसर क्या है और यहाँ और जो हमारी न्यू डिजीज आ रही हैं, तो ये हमारे एक कोर्स का हिस्सा बनना चाहिए, ताकि पेरेंट्स स्टूडेंट्स इससे पहले ही जो है ना वो उनको उनमें अवेयरनेस हो। तो मैं तो कहता हूँ कि एक तो हमारा टीचर्स भी ट्रेंड हो ना। अगर हमारा हेल्थ डिपार्टमेंट से कोई भी रिप्रेजेंटेटिव जाता है, उसको खुद को भी इसका पता नहीं है सर्वाइकल कैंसर का, तो वो एक टीचर को कैसे ट्रेन करेगा? तो उसमें ये देखें कोऑर्डिनेशन जो है हमारे स्कूल की टीचर्स की और हेल्थ टीम की, वो अच्छी होनी चाहिए।
बिल्कुल
जी।
ठीक है सर. So addressing misconceptions is essential. We all agreed. But we also need to communicate the positive. Dr. Alia, from both the public health and clinical perspective, how does the HPV vaccine contribute to long-term reproductive health? And how can we communicate its role in overcoming the barriers to early detection of cervical cancer in women and girls?
As we all have just discussed, the challenges faced by the women who has been diagnosed with cervical cancer, and the mere fact that this is a disease which can be prevented 100% by a vaccine, a disease which can be diagnosed very early by screening, and it can be adequately treated if we have all the resources, right? Now, if we have HPV vaccine, it is going to prevent this disease in a lot of areas of our population, and that will reduce the burden on the resources which are used for screening. So we are not saying that the screening has to be eliminated after the HPV vaccine, but the strength of the screening can be diluted, or it can be strengthened, or it can be redirected to those who have not reduced vaccine. As Dr. Fyezah Jehan's study has shown that the cancer was, or HPV 16-18 was more common in the higher age group, those which are not being targeted by our HPV vaccine campaign. So if the younger women or younger girls are being targeted by HPV vaccine, it will reduce the burden on our screening strategies or screening resources and the treatment resources. So in a way, HPV vaccination is improving the reproductive outcome or health of our women, and also because it is preventing from a cancer which can affect fertility. So we can put that as a main factor, that by avoiding or by preventing this cancer, we are actually improving fertility.
Right. Yeah, absolutely. So finally, none of these efforts will succeed unless the girls themselves feel informed and empowered. Samiha, how do we make sure adolescent girls are not just recipients of information, but active decision makers in their own health?
Right. So I want to talk about something called personal agency, which is the right to make your own decisions. Now, women in Pakistan have a huge lack of personal agency. Why is that? First of all, we're right at the bottom of the gender parity index. There's other issues as well, such as lack of information access, the power dynamics in a typical household, and mobility restrictions, financial problems. And one by one, we should solve all of these problems in order to make sure that our girls feel more empowered. We can do this by including cervical cancer awareness in schooling, by getting youth representatives to talk to them in local schools, clubs, and spreading accurate health awareness so that they feel the need to say that, no, I want this vaccine, and take charge of their own health. Thank you.
Oh, wonderful. So together we have looked at the barriers from the multiple angles, including the gender and the cultural sensitivities, trust building, accountability, school engagement, clinical benefits, youth empowerment. Now, this layered understanding is what will help us turn policy into real protection for every girl in Pakistan. Thank you all for staying with us through this rich and thought-provoking panel discussion on readiness and realities. Together, we have explored readiness of the health system to deliver, and which is the supply side, and the realities of the community willingness and readiness ability to accept the demand side. Now, if either side is weak, uptake will falter, even if the other side is perfect or robust. So, Yeah, so I would rather welcome questions from the audience now. I will give the comment, I won't take. I will give the comment, I won't take a question. सबसे बड़ी बात यह है कि अव्वल तो मैं उर्दू में बोलूंगी, अंग्रेजी में नहीं. सब सो रहे हैं, सब जाग जाओ. हम सब यहाँ पे मौजूद हैं. हमने सारी बातें सुनी है. हमें सबको पता है कि सर्वाइकल कैंसर बहुत हो रहा है, होता रहेगा अगर उसको प्रिवेंट ना किया जाए. प्रिवेंशन के लिए 9 to 14 को चुना गया, लेकिन जरूरी नहीं है कि 9 to 14 को ही लगे. ये कैंसर हर खातून को लग सकता है. 9 to 14 को गवर्नमेंट ने चुना है क्योंकि सबसे अच्छी पॉपुलेशन है जिसको हम प्रिवेंट कर सकते हैं. उसमें 0 HPV वैक्सीन, 0 HPV इन्फेक्शन था, तो हम आराम से उसको वैक्सीनेट करके फायदा उठा सकते हैं. इसलिए 9 to 14 किया गया. लेकिन ये नहीं समझना कि आपकी 25 साल बच्ची या 15 साल बच्ची को वैक्सीन नहीं लग सकता. उसको आप जाइए प्राइवेट पे 7,000 रुपए खर्च करवाइए और लगा लीजिए. लेकिन ये तो सरकार ने आपको सबसे बड़ी फिजिबिलिटी दी है कि आपको मुफ्त में वैक्सीन लग रहा है. तो यहाँ पे जितने लोग बैठे हैं सबको एक प्लेज करनी पड़ेगी, एक प्रॉमिस करना पड़ेगा, एक वादा करना पड़ेगा. वो वादा ये है कि हम इस चीज को फैलाएंगे कि सर्वाइकल कैंसर बढ़ रहा है और उसके लिए ट्रीटमेंट प्रिवेंशन मौजूद है. और जिस चीज के लिए प्रिवेंशन मौजूद हो, हमारा मजहब भी कहता है कि हमें उसके प्रिवेंशन की तरफ जाना चाहिए. तो प्लीज आप सब वादा करें, हाथ उठाएं और कहें कि इंशाल्लाह हम जाएंगे और अपने घरों से इस चीज को स्टार्ट करेंगे, अपने दोस्तों को बताएंगे, उस बात को फैलाएंगे. पॉजिटिव फैलाएंगे, नेगेटिव नहीं फैलाएंगे. एसटीआई का जिक्र नहीं करेंगे क्योंकि एसटीआई का जिक्र करने की कोई जरूरत नहीं है. आपको सिर्फ सर्वाइकल कैंसर प्रिवेंशन की बात करनी है. शुक्रिया बहुत बहुत. Thank you so much. जज्बा आपका काबिल कदर है. Any other question from the और सवाल ऑडियंस से, अगर हमारे पैनलिस्ट किसी से.
Can I ask?
Hello, Assalamu alaikum. My name is Dr. Maham. Basically, I don't have a question, I have a concern because as a public health professional, I have been to Matiari, I've been to Karachi also, and I've talked to the men of the community, right? So the men of the community, they don't talk about menstrual cycles, they don't talk about contraceptives. So for what is important for me is how will you involve them? Like, how will you get them to talk about HPV because they are the key players? How will you convince them to give their daughters all of those vaccinations? So especially the fathers of the community, like how are you involving them? Because when we talk about access, women don't have access. They cannot go to the vaccination centers. They cannot take their daughters to the vaccination centers. So they're the men who will actually go and take them to the vaccination centers. So how are we involving them? So my question is...
Yeah, I think Dr. Raj Kumar would answer this question.
Thank you, Ma. That's the real concern. So for that, if we will see the LHW program, so more than 60-70% LHW has the registration of the families. They have the access to the households. Just like ISIS, they have the access to talk with the mothers. Female to female talk, they can be about the all menstrual cycle, about their health, about their all concerns, she can talk with them. So we have just like a workforce involvement, 90% are the female health worker for engaging them for that HPV vaccination. So for the preparation is not be the just like we will go on the 15th September, but the registration, their advocacy, their sessions. So we have the multiple engagement stakeholders with us, CSOs, LAW program, NARI organizations, whatsoever female activists. So all are on board. So it's not be the easy task. It's not an easy task because the vaccination about the just like a community thinking is about the children, about the under 1 year. 9 to 14, it's be just like a sensitive topic. So we are multiple engagement sessions are going on all over the Sindh. So inshallah, we hope that we can succeed on that way.
Can I ask again?
I want to ask regarding, is this vaccine helpful with the neurodivergent girls? And if not, so then what we can do for them if we want to educate them and to stop this thing?
So I think that being neurodiverse does not give you a different biological profile, right? So the risk remains. So I think that yes, irrespective of because what we are emphasizing here is irrespective, and I don't know, to what extent you are talking about the neurodivergent issue, but generally this is irrespective of the marital status. This is irrespective of your sexual reproductive status, basically. So irrespective of whether you are living with your husband or your husband is away. So it's very important that every girl who is between 9 to 14 as a policy measure receives the vaccine, and there are no exceptions. Yeah.
That's the national policy for every vaccine. It's a national general policy. Individual variations may be at individual levels. Some physician may advise patient, for example, for a campaign with the polio, it's the duty of the oncologist treating that child that what vaccine that child should receive. On the TV, as a program will never say that the children who are suffering from the cancer will not be given the vaccine, because the children who are under treatment, their oncologist, their physician responsibility is they give them a letter, they show to the polio program that the child should not receive the polio vaccine, oral polio vaccine. So if there is a special situation, then their physician will will give them a letter, but overall as a journal will not make any differentiation. It is for all the Pakistani girls in this age group.
Can I ask the question? Actually, we are talking only about the young girls 9 to 14 years old, but this vaccine is not only for the girls. It is also for the boys. It is for the young men who particularly practice anal sex, and even the oral sex, the pharynx is carcinoma of pharynx is also common. So is the first phase, the most important group of population is the young girls age 9 to 14 years. But then older than that, up to 26 years, we can go, and women. And similarly, we have to protect our children, boys. We have to protect the men who have sex with men, and those who transgender population, and female sex workers who have the highest risk for this particular sexually transmitted infection.
Actually, the thing is very clear. This is about the vaccine. No. This is a national policy about this vaccine. Will vaccinate all the female children from 9 years to 14 years of age. And subsequently, this vaccine will be included in our national EPI program for all the girls in the Sindh from 1st January 2026, attaining the age of 9 years will be given this vaccine. From where we have to start? Like the typhoid is very common, but which age we vaccinate? Where the incidence is high or where the protection will work better. So this is the best time to vaccinate. Even if a commercially vaccination available, this was the recommendation that should be given before this age group. So this is in accordance with the national international standards and according to the economical state, how much resources we can allocate. Dr. Shaf has mentioned that this vaccine may be given to males, but the male have very low risk of this disease. They can transmit the disease, but mainly the victims are the female from the cervical cancer. And we will publicize this vaccine as a vaccine against cervical cancer. That will be of the key to success. If we go into the details of the HPV infection and these things, the people will be distracted too much.
Hello. Thank you, Dr. Muslima. I'm from infectious diseases, and my mind always, runs towards that. I don't know if this has been discussed earlier. I missed the earlier session, so if I'm repeating myself, please bear with me. But decades ago, you made a pitch for vaccinating with hepatitis B, which protects against not only cirrhosis, but also against liver cancer. And you also make a pitch for hepatitis C treatment, saying that it will prevent cirrhosis and also liver cancer. So why can't we use the same pitch over here, the same advocacy? This is a vaccine which will also prevent cancer. Hepatitis B can be prevent, and this is also going to prevent. You don't have to emphasize where and how and what. That's the point. Thank you. We are promoting that one. I have a comment.
Assalamu alaikum. I'm Dr. Inas. I did a study regarding HPV vaccination readiness among the population under the supervision of Dr. Muslima Ijaz. The one thing that my study brought me up, that our healthcare providers are not aware of this vaccination as well. So what are the things in line to educate them? Our general physicians, only the gynecologists are aware of it, but general physicians, pediatricians, they don't know about it. So what are the things to solve this thing?
When you conducted this study?
In 2023.
This vaccine is approved to be included in the national program around 10 years back, and the publicly it just announced few months back. So how can our people may be aware about the physician and other that this vaccine is going to include it? Rather, it was not commercially available in Pakistan. Once it was available, but due to certain marketing reason, it was withdrawn. So this vaccine was available outside Pakistan. We, all the persons, pediatricians, we are aware. But general physicians, they are not well aware because this vaccine is not even available at private market.
It was
So
available
this cannot be a thing that they are not a no. Everybody will be aware in the next 15 days, inshallah.
Sir, I take your point and I take your point as well because she did the thesis with me, sir. Absolutely right. डॉक्टर शरफ ने अभी रेस किया है कि हमको जनरल फिजिशियंस के ऊपर ट्रस्ट है कम्युनिटी का एंड दे आर यू नो द पीपल हु कैन promote this vaccination uptake. So there is a role of general physicians, sir. हम उनको exclude नहीं कर सकते. So we need to, bring them to, on board. Dr. Fyezah.
So now I'm speaking as a chair of the Department of Pediatrics, and the role that the Department of Pediatrics has had in the advocacy of different vaccine preventable illnesses, both in data generation for bringing the vaccine into the country, as well as doing post implementation studies, etc., etc. So I think I personally feel that we have not done enough as a very reliable healthcare provider. The हमारा जो पूरे हमारे जो professors वगैरह हैं जो कि as consultants काम करते हैं AKU में, we are considered a very reliable source of information. But I think that you guys have not tapped us enough. Our outreach, especially towards the private schools, because obviously AKU is considered that the reach of a certain segment of the society is better at AKU. Now, I have reservations about that because I believe we see the same amount of rich patients compared to the same amount of poor patients, because Aga Khan is the end of the line place for many people. तो बहुत सारे लोग मजबूरी में भी आते हैं और हम उनको support करते हैं. But coming back to the point, I think that we can really help you with those 6 or 7 lakh girls in the private sector, because our voice, and I'm talking about, as a Department of Pediatrics, even Dr. Alia, like her direct care of cancer patients and the stories, we need to bring those stories out, and we need to find avenues where we can we can have an interaction with the public for your benefit. And this is something that I want to say, that we can have a much more bigger role in the advocacy.
Can I say the last thing?
Yes, please go ahead, Doctor.
In accordance to you, I'll just give you an example. I have one daughter, and she went to university. When she went to university, she had to produce her vaccination card and what vaccination she has received. And I received a call. I received a call, Mama, you don't love me. And I said, from where it's coming? I said, what happened? Mama, you don't love me because you have not given me one vaccine which is supposed to prevent me from cancer. So I said, Beta, who did told you that? My school nurse who was checking my vaccination, she said, I have not been vaccinated with HPV vaccine. So I was like, shocked and taken aback. I said, Beta, it was because it was not available in Pakistan. And you have lived all your life in Pakistan. You have just now gone back. So she said, okay, now I know that you love me, but can I take the vaccine now? So I said, yes, you can take it. So you can imagine that girls are very intelligent if and they know their rights, and they can come after you that, why you are preventing us from taking a vaccine which prevents us from cancer. So this is the role of GP or over there, the school health nurses, and we can utilize this, as Fyezah said, in going to private schools and encouraging them or imparting the education about what is HPV vaccine and how preventive it can be. To the mothers, yeah.
Completely agree. So we have science, we have policy momentum, we have voices from the communities. Now it's the time for the collective action, collaborations, and advocacy. With a pledge to Abhi unse liya jazbe mein कि no one girl is going to lift for the prevention.
Excuse me.
With this,
Can I ask the question?
Still question? Where? Oh, sure.
If your girls who are above that age, that is 9 to 14 years, is nominated by the government policy. But in our private practice, if the girls are coming who are 25 or 30 years old and they are also married and they want to vaccinate, so either it is necessary we should first screen them or we should direct vaccinate them.
See, screening is only going to screen for certain high-risk viruses, all right? And many screening tests are not covering the whole spectrum of the high-risk viruses. So I would say even if they are married and if they can be vaccinated, if a vaccine is available and you can afford it, yes, you can. But that would not take the importance of screening away. You still have to educate them about the role of pap smear and HPV testing and
But
how
we can
frequent
vaccinate them.
Yes,
We can
you can.
vaccinate.
Yes, you can vaccinate.
Okay. So thank you so much. With this, I end my panel discussion. Thank you so much, for sharing your points with this important, vital dialogue. Thank you. Panelists. Please, you stay here. We are going to take a picture. All the panelists, please.
So while everybody is lining up, I want to give a big heartfelt thank you for all the participants who stayed on despite the challenges of technicality and time, and also very, very grateful to all the representatives from our very, very key stakeholders for this rollout. So thank you so much. Thank you, everybody. And I think there is tea outside.
I think, yes.